Auzubillahi minasyaitonirrajim. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. I'm Zaitulhusna binti Mat Safee, pharmacist from Institute Kanser Negara Putrajaya. I've been working in this area of nuclear pharmacy since 2006. My first posting was in the Radiopharmaceutical Preparation Facilities Cyclotron under the Hospital Putrajaya. It was then in 2009 I've been posted to the Nuclear Pharmacy Unit of Hospital Kuala Lumpur. It was then last year 2019 where I come back to the same facility, Radiopharmaceutical Preparation Facility of Cyclotron, but now under the management of Institute Kanser Negara. So today I would like to share with all of you about the characteristic and quality control of the. So this is our scope of presentation, which I hope at the end of this lecture you will be able to cover most of the stated things here. Yeah. Okay, working in the nuclear medicine department, obviously, I think you are aware that radiopharmaceuticals are the core businesses. And obviously, being a pharmacist, this is going to be a very crucial things that we really need to know. So the radiopharmaceuticals, they are defined as a chemical substance that contains radioactive atoms within its structure. They are suitable for the administration to humans, not only for the diagnosis, but also for the treatment of the disease. So basically, we have those two components, whereby some of people call it a carrier. It can be the chemical or biological carrier, which will bind with the radioisotopes, and it will make up of this radiopharmaceutical. So for example, we have the MDP as a chemical or biological carrier, which will be bind with the sodium pertagnetate from the generator, and it will make up this technetium 99M MDP. So this is our bone imaging agent, whereby we will inject it to the patient, and then we will image the patient, and this is where we come up with the picture of the or image of the scanning after the patient has undergone the SPECT camera. So these radiopharmaceuticals, they are used to be injected to the patient intravenously. So due to this intravenous injection, those criteria need to be adhered for it to be safe and efficacious to be injected. Radiopharmaceutical at the nuclear medicine department or nuclear pharmacy, they can categorize into a few. One is actually our kit-based radiopharmaceutical, mainly where we have this technetium radioisotope, which will be bind with the pharmaceutical kit, so that it will need us to do the quality control of the radiopharmaceutical before it be injected to the patient. However, we also have this sort of a ready-to-use radiopharmaceutical, whereby we just receive them and then we can just directly inject them to the patient, or the patient can ingest through, because it is in the liquid or in the capsule condition. So in terms of the ready-to-use radiopharmaceutical, we can actually have the certificate of analysis prepared by those manufacturers to ensure the quality of product before we administer to the patient. But for the kit-based radiopharmaceuticals that I mentioned just now, because we have to prepare it daily at our facility, so we have to ensure that the quality control of radiopharmaceutical being done. So this QC is necessary for two distinctly separate but linked reasons, as they related to the pharmaceutical parameters as well as radioactive parameters. For the pharmaceutical parameters, it is designed to ensure that no microbiological, pyrogen, or particulate contamination which can harm the patient. Whereas the radioactive parameter is designed to ensure that the intended radiation exposure of patient is kept to a minimum by confirming that the radioactivity, the radiochemical as radionuclidic purity are assured. So these additional factors have an effect on the overall radiation dose to the patient, as impurities of the radionuclide and or its chemical composition may affect the biodistribution of the injected radiopharmaceutical, and consequently the radiation dose to any particular organ or the whole body dose will affect the effective dose. So one of the methods for assessing these pharmaceutical parameters is the pH. So the pH of the preparation should be in the physiological acceptable range between 5 to 8, or at the optimum pH for the stability of the preparation. So it is especially important to check the pH of PET radiopharmaceuticals, because we've got to bear in mind sometimes during the preparation or manufacturing of the PET radiopharmaceutical, in the preparative operating procedures, it may include an extreme pH condition. So due to this, the neutralization need to be done. So this is a very important for us to check the pH of the PET radiopharmaceutical before we release the product. So the pH can be checked either by using the pH paper, where we just place a drop of solution on the pH paper, and the reading of the paper is done by referring to the colorimetric pH scale. And also we can use these micro pH meters which are available. They can actually read a drop of liquid about 10 microliter when we place those liquid on the electrodes. Next would be the apyrogenicity. So all radiopharmaceuticals for human administration are required to be pyrogen-free. So these pyrogen or bacterial endotoxins are either polysaccharides from the bacterial membranes. They are water soluble, heat stable, and filterable, whereby they can cause a fever as well as leukopenia in immunosuppressed patients. So it is noteworthy that sterility of a solution does not guarantee its apyrogenicity, and sterilization process does not destroy the pyrogens in a radiopharmaceutical. So there is no specific method for making a sample apyrogenic, so the necessary precaution should be taken from the beginning to minimize the chances that pyrogens are present. So this is why it is very important that the preparations are manufactured and dispensed under aseptic condition, and the consumable as well as the equipment that we're going to use have to be heat treated or gamma sterilized and known to be pyrogen free. So the most popular method is the LAL test. Yeah? Then the visual examination. As with all pharmaceutical preparation, the radiopharmaceutical should undergo a visual examination. However, the examination should take into account the radiation protection issues for the operator. So it needs to be conducted as quickly as possible with the preparation behind suitable sheeting. So yeah, because other pharmaceutical, we can actually observe it directly with our naked eyes. It can be put as close as possible to the operator, but for this radiopharmaceutical, because it will give a radiation out from the solution, so you can't actually do those things the same as what you're doing with the pharmaceuticals. So you have to ensure that you're doing it behind the shielding, meaning the lead shield. Okay. So the vial should be examined for the insecure closures, any cracks, or any glass particles in the liquid, and also if there's any particulate contamination. This is not only for the vials, it should also be done to the syringe, whereby we have to examine if there's any particulate contamination there. Next would be the sterility test. The sterility testing is performed to ensure the radiopharmaceutical are highly free of viable microorganism, including the fungi and also the bacteria. So these tests must be performed aseptically so that external contamination unable to interfere to the test sample during the experiment. Yeah, because we just don't want that during the testing, when we are doing it in non-aseptic condition, it will contribute to the contamination to the plate that we are doing. So a sterile laminar flow hood and well-trained personnel need to perform this test. So this is preferable to be done by the trained personnel. So in the USP 32, it indicates that sterility tests are performed by incubating the radiopharmaceutical sample in two different ways in order to detect bacterial and fungal contamination. So for bacterial contamination, the radiopharmaceutical sample should be incubated in the fluid thioglycolate medium TSA at 30 to 35 degrees centigrade for 14 days, and for fungal contamination, the radiopharmaceutical sample should be incubated in the soybean casein digest medium, the SDA, for incubation at 20 to 25 degrees Celsius for 14 days. So the sample volume for the test should be at least as great as that for a human dosage. If bacterial growth is observed in either test, the radiopharmaceutical is not sterile. So the most prominent drawback for the radiopharmaceutical sterility test is that this sterility testing frequently takes longer than the half-life of many common short-lived radionuclides such as technetium. They have like 6-hour half-life. Obviously, we have to do the sterility test for about 2 weeks. So the results of this sterility test come out after a long way we have already injected the radiopharmaceutical to the patient. So in these cases, the product of interest is released for human use, provided the manufacturer has already established its sterility and apyrogenicity at the production level. So meaning we have some data to show that our preparation is sterile and apyrogenicity. So after that, we can actually inject those to the patient, but we will have the data after 2 weeks. It been done the sterility test. So now we move to the methods for assessing the radioactive parameters. There are very strict limits on the amount of radioactivity that can be administered for each type of investigation to be performed. So these limits are set by legislative bodies in individual countries. So it depends on each country's requirement. Therefore, all radioactive preparations must be checked for the activity before administration. So this is something like our paracetamol. We've got doses that we need to supply according to the indication. So this goes the same for the radiopharmaceutical. For example, our DTPA for renal imaging, we have to actually administer for the patient in 5 millicurie. So we have to measure the activity of this DTPA before we inject to the patient. So most radionuclide calibrators used in radiopharmacy are ionization chamber. Commercial calibrators, they have built-in scaling factors for individual radionuclides that take into account the ionizing ability of the isotope and give a readout in the appropriate unit, whether kilobecquerel or megabecquerel or millicurie. However, this type of calibrator is not ideal for all radionuclide because low energy radiation, such as that produced by iodine 125 for example, it may be attenuated before reaching the gas and the measurement may be inaccurate. So also high energy beta particles interact with the chamber wall and the measurement of activity is based on the Bremsstrahlung radiation produced. So there are some of the limitation occur, but currently with the one that we are used to inject to the patient, such as technetium 99M as well as iodine 131, we don't have so much issues. However, we have to bear in mind that the activity dispensed need to be measured to a precision of 10%. So as I've mentioned just now, if we are about to administer our renal DTPA dose, which by right, the administration dose is about 5 millicurie. We have to ensure that the activity is plus minus this 5 MCI. And it is very important that the radionuclide calibrator used is working correctly and a strict quality assurance regime should be followed to ensure this. So daily, the calibrator is checked for accuracy against a long-lived referential source. So we are using our cobalt 57, our cesium 137, as well as our there is another long-lived radioisotope that barium, our barium. So to do the constancy check for the calibrator before we use the calibrator to measure the dose that we are going to give to patients. Then we have this radionuclide identity. So a radionuclide can be identified by measuring the half-life of the radionuclide and or determining the energies of the emitted radiation. So the half-life is measured with a suitable detector. There must be sufficient activity in the sample so that it can be measured for several half-life, but limited to minimize count rate defect and effects such as daytime loss. Sebab kita tak nak it's very high that it will cause daytime losses to the dose calibrator. Multiple measurements are made in the same geometrical condition for a time at least equal to 3 expected half-life. So, for example, we've got our fluorine 18. So we used to have at least 3 expected half-life. Then a graph is drawn with the logarithm of the instrument response against time, and the half-life is calculated from the graph and should not differ by more than 5% from the half-life stated in the pharmacopoeia. The nature and energy of the radiation emitted may also be determined by several procedures depending on the type of the radiation emitted. So radionuclides which emit gamma rays or detectable X-rays can be analyzed using the gamma spectrometry. So the spectrum can be used to identify which nuclides are present in the source and in what quantities they are present there. These are followed by the amount of radioactivity, the radionuclidic purity. This is the amount of radioactivity due to the radionuclide concern compared to the measured activity of the radiopharmaceutical preparation. So it is usually expressed as a percentage. So the relevant monograph in the pharmacopoeia give limits to the radionuclidic impurities allowed in each preparation. If significant level of other radionuclides are present, then biological distribution may be altered. So this is why we have to have the radionuclidic purity being calculated. So radionuclide impurities, they can actually occur as a result of the manufacturing process. For example, for the nuclide produced by cyclotron, there can be contaminants due to impurities in the target or by the energy of the reaction. So for example, we have yttrium-86 for use in PET. It is produced by the reaction PN on a target of strontium-86. It used protons with energy of 16 MeV. So if an energy of 30 MeV is used, then yttrium-85 is also produced, which decays to the strontium-85. So this radionuclide has a long half-life and it will target the bone, which will have a serious implication for the patient. On top of that, impurities can also arise due to the presence of the parent nuclide of the stated nuclide when the stated nuclide is obtained by a separation technique. So for example, this is from our generator illusion. The presence of molybdenum 99 in a solution of technetium 99 M. So the presence of molybdenum in a technetium radiopharmaceutical would be detrimental for patients due to the beta emission of the radionuclide. And the molybdenum, they have a very long half-life of about 66 hours, which will give an increased radiation dose if it been injected to the patient. We will have clear example for this molybdenum breakthrough in the next slide. So the radionuclidic purity, they can be determined by the gamma spectrometry or by the determination of the half-life. So the half-life method is useful for very short-lived isotopes such as in the PET. For example, our oxygen 15, because its half-life is about 2 minutes. Okay. A version of the attenuation method can be used to determine the amount of molybdenum in a solution of technetium. Because these two radionuclides, they emit gamma radiation at different energies. So the activity of the sample is determined in an ionization chamber on the technetium setting. The activity measured will be due to the technetium 99M as well as the moly 99M. Then the sample is then placed in a lead canister with wall thickness of 6 millimeters and measured again on the molybdenum setting. And now the radiation emitted by the technetium, which has an energy of 140 keV, will be absorbed by the lead. So the radiation emitted by the moly with energy of 740 keV is only attenuated by a third. So the any measured activity is therefore due to the molybdenum present. So we now know the proportion of the molybdenum in the sample, which we can actually calculate. So this one I will actually give more example in other slides. Yeah. Next would be the radiochemical purity. So it is important to know that the majority of the radioactive isotope is attached to the ligand and is not free or attached to another chemical entity, because as this form may have a different biodistribution. So this is the radiochemical purity, because we want to ensure that if we made up the technetium MDP, so we have a high radiochemical purity of these MDP. So we can ensure that all those MDP will go to the patient's bone instead of other organ. So in diagnostic scanning, the different biodistribution of contaminating radioactive chemical could interfere with the clinical diagnosis by obscuring the region of interest and will interfere with the interpretation of the scan. So if the images is not as what we desired, this could result in the patient returning to the department for a repeat scan with all the cost complications for the department and a repeat radiation dose for the patient, or more seriously, to misinterpret of the images. So abnormal biodistribution can also be due to other causes such as patient medication. So therefore, determining the RCP could help to clarify any abnormal scan by ruling out defective product. So in radiopharmaceutical use for therapy, a low RCP could mean an unacceptable radiation dose to the healthy organs as well as tissue. For your information, most of the radiopharmaceutical has the lower limit of RCP of 95%. So that is, at least 95% of the radioactive isotope must be attached to the ligand. And this RCP determination can be carried out by a variety of chromatographic methods. So this RCP can be carried out by a variety of chromatographic methods such as paper and thin layer chromatography. So in this method, a small drop of the radiopharmaceutical is put on the bottom of the strip on the support medium. It can be paper, silica gel coated sheets, and then the strip is put into a tank containing a small amount of solvent. Then the solvent migrate up to the strip. The components of the radiopharmaceuticals then are separated according to the solubility in the solvent and adsorption to the support medium. The detection of the radioactivity in the strip then can be carried out in a number of ways. It can be measured through cut and count method, gamma camera, radioactive scanner, as well as storage phosphor imaging. And then we have this solid phase extraction, the SPE. So a variety of bonded silica solvent are available packed into the disposal disposable cartridge or column. So the sorbent will selectively retain specific type of chemical compound from the sample loaded on the column. So there are many different sorbent available and many suppliers as well as manufacturers of the SPE columns and cartridge. Components can be selectively eluted by careful choice of solvent. So eluates are collected and have sufficient activity that they can be counted in a radionuclide calibrator. So the procedure sometimes takes about 5 minutes, ensuring that the RCP determination can be carried out before administration of the patient dose. And on top of that, we have this high performance liquid chromatography, the HPLC. I think you guys already covered in other pharmaceutical lecture. So the TLC-RCP method may not be sufficient to identify all the compounds which are present in a product. So HPLC has a higher sensitivity and resolving power than the simple TLC method. So the HPLC separation operates on the hydrophilic or lipophilic properties of the components of a sample applied. And sometimes you are using the gamma emitters. Gamma emitters are detectors using a Wells scintillation counter connected to a rate meter. And other detectors such as UV or refractive index can be connected in series, allowing simultaneously identification of the compounds. However, we should take into account that it should not be necessary to perform HPLC on radiopharmaceuticals reconstituted from the licensed school kit. It is useful to have techniques available for the purpose of eliminating cause of any abnormal patient scan. So for radiopharmaceutical prepared in-house or novel compounds for research purposes, and HPLC method for estimating radiochemical purity is very essential. It should be noted that the HPLC does not detect colloidal contaminant and that this could be estimated using the TLC method. Then we have the electrophoresis, where it separates component in a sample according to the charge and size of the molecules. The most frequently used electrophoresis method in radiopharmacy is the RCP determination of radiolabeled albumin, where the sample is run on a support of filtered paper in a barbitune buffer. Next will be our chemical purities, which requires the identification and quantification of individual chemical constituents or impurities in a radiopharmaceutical preparation. So a routine test for chemical purity is performed on the technetium-99m sodium pertagnetate solution eluted from a generator. So because this technetium eluate may be contaminated with the aluminium, which originates from the alumina bed of the generator column. And I will explain this more in next slide. So okay, now I would like to bring your attention to the quality control test that we are doing at our nuclear pharmacy setting. So this is an example of our Moly 99 technetium 99M generator. I hope you are aware that about 80 to 90% of the radiopharmaceuticals used in the nuclear medicine department is categorized under the diagnostic radiopharmaceutical, and the preparation of the kit-based radiopharmaceutical or technetium 99M radiopharmaceuticals are the most common. So, technetium 99M eluate from a technetium generator will contain a small amounts of a variety of impurities. Since the technetium activity is used for human, several quality control tests of the technetium eluate are mandatory. So this is a dry column generator. They are internal construction. If you can see on the left side of the slide, we've got this technetium pertagnetate in sterile evacuated vial, where we will have a lead shielding to put our SEV in. And then we will have the 0.2 micrometers filter before we have the pertagnetate eluted in the SEV. Then we have this column with the alumina bed on it, and this is where our moly 99M is adhered to. So they are adhered to the alumina column. And on the right side, we have this 0.9% sodium chloride as our solvent or our material that's going to be eluted into the alumina column. So for the dry column generator, first we will insert this 0.9% sodium chloride, and then followed by insertion of this sterile evacuated vial in a lead shield. So once we actually insert the SEV, the sodium chloride will pass through the alumina column, and as the moly 99 decay into the technetium 99M, the saline will bring out, when it goes through the alumina column, it will bring out the technetium pertagnetate into the sterile evacuated vial. So in this internal construction, you can see there is the molybdenum as well as the alumina in the column. So our main impurities would be these molybdenum as well as the alumina. And this is the reasons why we have to do this molybdenum breakthrough test as well as iron aluminium or alumina breakthrough test. So now we are going to move to the molybdenum breakthrough test. So moly 99 contamination in the technetium eluate and originates from the small quantity of moly 99 that may be eluted with the technetium 99M. So the US pharmacopoeia limit is 0.15 microcurie of moly 99 in 1 millicurie of technetium 99M at the time of administration. So for moly 99M generator, the molybdenum breakthrough needs to be determined only for the first elution. The moly 99 contamination is measured by detecting 740 keV and 780 keV photons of molybdenum in a dose calibrator or a sodium iodide detector coupled to a pulse height analyzer. So the eluate vial is placed in a lab pot about 6 mm thick to stop all the 140 keV photon from the technetium 99M and to count only 740 keV and 780 keV photon from the molybdenum 99. The shielded vial is then assayed in the dose calibrator using the moly 99M setting. Molybdenum 99 along with moly 98 from the molybdenum target can also be detected by adding phenylhydrazine to the eluate and observing the color change due to the moly phenylhydrazine complex by the use of a colorimeter. However, in most of our setting, we are using this molybdenum carrier lab pot. Yeah. So this is an example of those molybdenum breakthrough tests. In the technetium eluate, we will have both moly 99 as well as technetium 99M. But when we put in the molybdenum shield canister, only the molybdenum photon will be transferred out through the shield. So we can just measure the moly 99M value. So in the procedure, we might need the dose calibrator as well as the molybdenum shell. Using a calibrated dose calibrator, set the assay for moly 99 or the most sensitive radioactivity scale. With the empty moly assay shield in place, zero the calibrator or note the background activity. Working behind the lead shield and using transfer tong, transfer the pertagnetate eluate vial from the elution shield to the moly assay shield. Place the moly assay shield containing the eluate into the calibrator well. Note the display activity in the microcuries. So subtract the background activity and determine the net moly 99 activity as measured in microcuries. Then calculate the total moly 99 activity by multiplying the net moly 99 activity by the moly assay shield attenuation factor. So this factor is supplied by the calibrator manufacturer and can be found in the operation manual for the dose calibrator. Then we record the total moly activity and the time of assay on the appropriate record. Divide the total moly 99 activity in microcuries by the total technetium 99N activities in millicuries to obtain the ratio. So this is the detail of it. Change the dose calibrator setting to moly 99. Remove the vial syringe dipper from the dose calibrator. Measure the background activity of the empty moly shield in microcurie. And then we put the technetium 99M vial into the moly shield and measure the activity in microcurie lah. So this is how we calculate readings of the technetium 99 is about 639 MCI per 10 ml. In the moly shield, when it's empty, it's 5 microcurie. When we put the technetium eluate in the moly shield, it gives us 50 microcurie. So now we can calculate the content of moly 99 is 50 minus 5 over 639 MCI. So we now get 0.07 microcurie of moly 99 per MCI of technetium. And this actually, the standard is need to be less than 0.15 moly 99 upon 1 MCI of technetium 99M. So the QC then pass. Next, we move to the aluminium breakthrough test. So the aluminium contamination originates from the alumina bed of the generator. The presence of aluminium in the technetium 99M eluate interferes with the preparation of the technetium sulfur colloid, particularly phosphate buffer in colloid preparation. It tends to precipitate with the excessive aluminium. It also interferes with the labeling of red blood cell with the technetium 99M, which cause them to be agglutinated. And the USP limit is 10 milligram of alumina per mil of technetium 99M for fission-produced moly 99. So the presence of aluminium can be detected by the colorimetric method using aurine tricarboxylic acid or methyl orange, and it can be quantitated by comparison with a standard solution of the aluminium. The test kits are commercially available for the determination of alumina. In this kit, the strip containing a color complexing agent are provided along with a standard solution of aluminium, which is about 10 milligram per ml. So 1 drop each of the technetium eluate and the standard aluminum solution are spotted on a test strip, and the intensity of the colors of the two spots are visually compared. So if the technetium eluate spot is denser than the standard aluminum spot, then the amount of aluminium is considered excessive and the technetium eluate should be discarded. Excessive amount of aluminium in the eluate indicate lack of stability of the column. So if we can see more detail, take one strip of the indicator paper, place one drop of aluminum solution, 10 ppm or 10 microgram per mil on the paper. We swap the technetium vial, draw a small volume of the technetium eluate, then we place one drop of the technetium eluate on the paper and compare the color. So in this paper, we can see that the QC is passed. Next is the pH. The pH of the eluate should be between 4.5 and 7.5. This can be checked quantitatively with a pH meter or qualitatively with a pH paper. So the actual pH of technetium eluate from the generator is about 5.5. The pH of the technetium solution obtained by methyl-ethyl ketone extraction is slightly higher, about 6 to 7. So this is how we do the pH test using the pH strip. A drop of technetium eluate is placed on the pH paper and compare the color to the reference scale in order to determine the pH, and the standard is between 4 to 8. We swap the technetium vial, draw a small volume of the technetium eluate, then place one drop of the eluate on the paper. Then we can compare the color with the given scale. So now we are going to move to the quality control test for the radiopharmaceutical. As I've mentioned earlier, we've got this kit-based radiopharmaceutical for our technetium radiopharmaceutical preparation. We have the radioactive material from the technetium 99M from the generator. Then we bind it with the pharmaceutical kit, for example, the methylene diphosphonate, the MDP. So it will now become the technetium MDP. So, for example, we draw out about 15 gigabecquerel of the pertechnetate and dilute it with the normal saline up to 8 ml. Reconstitute the MDP, leave it for 10 to 15 minutes. Then we will do the quality control. This is one of the very important steps before we actually syringe out about 700 megabac, depend on the body weight, and then we supply it to the technologies for it to be administered to the patient. So the main impurities in the technetium pharmaceutical preparation is the free pertechnetate or reduced hydrolyzed technetium, our technetium colloidal. So it may be separated from the technetium pharmaceuticals by the thin layer of paper chromatography. So in principle, a mobile phase, the solvent, it will move along a layer of adsorbent, the stationary phase, due to the capillary forces. And the radioactive sample going to be spotted onto the adsorbent, which will migrate with a different velocities. So these impurities going to be separated. So the main principle of separation are adsorption, electrostatic forces, partition, the solubility, and also the ion exchange based on its charge. Depending on the movement of the mobile phase, the TLC may be ascending or descending. So in the nuclear medicine laboratory, ascending TLC is the method of choice. For the analysis of radiopharmaceuticals, the technique should be fast and safe. The TLC offers reliable separation properties with easy and rapid performance. So in order to separate and quantify two or more impurities, two or more analytical systems are generally used. In organic solvents such as methyl ethyl ketone, the colloidal form and technetium complex will remain at the origin, whereas the free pertechnetate will migrate with the solvent front. So we will be able to quantify this free pertechnetate. Whereas in saline, the free pertechnetate and the technetium complex will migrate with the solvent front, and the hydrolyzed technetium 99M will remain at the start. So we will able to identify or quantify the colloidal technetium 99M. So the distance each component of a sample migrate is expressed as the RF value. So the RF is the relative migration of a component in relation to the solvent front. So RF is calculated by distance from origin of the component to the distance of the solvent front. And the RF value will range from 0 to 1. So for example, if the component migrates with the solvent front, the RF is 1. If the component remain at the origin, the RF is 0. So for example, we have these components. We have the origin. We spot it at the origin, then we put it inside the solvent front. It will migrate up to the 6 centimeters to the solvent front, but the radiopharmaceutical is actually stuck at 4 centimeters. So now we can calculate the RF, meaning 4 centimeters divided by 6 centimeters of the solvent front. The result is 0.67. So the RF is 0.67. So this is an example of how we calculate the RF value for those method. Yeah. Saline or MEK system analysis of most radiopharmaceuticals that contain a free pertechnetate and or colloidal pertechnetate. Acetone has colloidal technetium. Acetone has been replaced by MEK because artificially high values of pertechnetate have been obtained. It caused by its higher water content. So develop technetium complexes, it will require more sophisticated analytical method to detect additional impurities in the injection solution. For example, MAC3, maybe as well as HEMPAL. So this is the list of solvent for the mobile phase, and the one red in color is those being used in our nuclear pharmacy setting. You can have a read afterwards. And this is the next list of solvent for the mobile phase. Yeah, for example, ethyl acetate as well as MEK is regularly used. Next would be the 20% sodium chloride. So this is the stationary phase. In Malaysia, most of the nuclear pharmacy unit using the miniaturized chromatography strip, and the brand name is the tech control. So this chromatography strip consists of different types of support media. You can see the example of the support media used for those miniaturized chromatography strips. It can be ITLCSG, ITLCSA, as well as Gelman solvent saturation pad, Whatman 31 ET, as well as Whatman 17 and Whatman 1. So this is a typical miniaturized chromatography strips. We have it on the left. It's about 0.7 centimeters times 6 centimeters, whereas the common one is about 0.7 times 7 centimeters. Okay, so they already have this line for us to identify where is the origin, where is the solvent front, as well as where we have to cut the line into 2 areas. So from the figure above, the developing distance and the location for cut line will depend on the migration of the specific radiopharmaceutical. And the advantages of that control is color coded for easy identification and appropriately numbered depending on the chromatography system. So this is the chromatographic data of technetium labeled radiopharmaceuticals. Those can be seen there. What is the stationary phase can be used as well as the solvent. And it will clearly state where the pertechnetate will migrate and where the technetium complex as well as hydrolyzed TC will be adhered to. And this is the continue of the other radiopharmaceuticals, and this is other radiopharmaceuticals. In terms of spotting of the sample size has a considerably effect on the separation characteristic of a certain system. Therefore, the sample diameter on the media should be kept as small as possible, if possible less than 3 mm. Too large spots, it will give an inefficient separation and artificial results. So, in terms of spotting of the sample, sample is withdrawn aseptically using a 1 ml syringe with a fine needle, if possible more than 25 gauge, and is spotted directly onto the media using a single drop from the needle. The volume corresponding to a drop from a vertically held needle, if 25 gauge, is approximately about 6 microliter. If the syringe is held in the horizontal position, the volume might be double. With experience, reproducibly small spots are applied to the TLC media suitable for analysis. The technique also avoids contamination and minimize sample exposure to the air, which may affect certain technetium-99m radiopharmaceuticals. In terms of development of the chromatogram, a small beaker closed with a glass plate or covered with a foil to maintain a saturated atmosphere inside the vessel. If an open beaker is used, evaporation of the solvent may affect the separation properties of a system. So you have to ensure we need to actually close the beaker to ensure the atmosphere inside the vessel is well saturated. In terms of development of the chromatogram, the solvent level has to be below the start line on the strip. After spotting, place into the tank and develop immediately without drying the spot. Dry spot, it will give artificial results due to oxidation of technetium complexes and formation of free pertechnetate. An exception to this rule is made for mobile phases that do not dissolve the aqueous sample. For example, the ethyl acetate or chloroform. Usual developing time is about 2 and 15 minutes. It depends on the stationary phase and to a lesser extent on the solvent. So now we can have a look on the determination of RCP of radiopharmaceutical by ITLC using two different solvents, the MEK and the saline. So we spot the radiopharmaceutical, then we develop inside the MEK for the top portion, methyl ethyl ketone. And then after the development, we can see that the free pertechnetate will actually move to the solvent front. Then we do the cut and count measure, or we can do a scan. If you do the cut and count measure, if let's say we just already know that the free pertechnetate will actually migrate to the solvent front with the RF value of 1, we can just cut it into 2 pieces. If we don't know where it migrate to, we can actually cut into 0.8 5 centimeters. So from there we can actually quantify those activity at that 0.5 portion, and then we can identify where the RF is. Okay, for the bottom level is the sodium chloride 0.9%. So after development in the solvent system, the colloidal TC is actually at the origin, whereas the label compound and free pertagnetate migrate to the solvent front. So we can do the same, the cut and count, if we just have our dose calibrator available. We also can do the using the TLC scanner if we have the radio TLC available. Then we can have the radio chromatogram. Okay. So from this, we can identify the value of our label compound. Yeah? So the ITLC plates before and after development, typical dimension, the application point is marked with a line. A color pen marker may be used to mark the solvent front. When the solvent reaches the marker, the color migrates with the solvent. So markers are positioned outside the track to avoid interference with the sample. So we able to notify if the solvent has already migrated to the solvent front by using this method. So measurement of radioactivity, there are several methods for quantification of chromatogram. Depending on the available instrumentation, the resolution of analysis will vary. The amount of measurement are used to calculate the radiochemical purity of radiopharmaceutical in percentage as the ratio between the corresponding to the main component. It divided by the total recovered radioactivity of the chromatogram. So RCP is based on the radiopharmaceutical activity divided by the total recovered activities and time 100. And this is the common error when we are doing the radiochemical purity. Sometimes origin where strip spotted is below the initial level in the developing vial. So the activity will distribute throughout the entire chromatography strip, resulting in inaccurate result. So we have to spot a new strip correctly. Strips are counted in dose calibrator. So insensitivity of dose calibrator may result in large errors when counting low activity strips. So if possible, we have to spot more radiopharmaceutical activity on strip prior to develop. So this is if we are using the dose calibrator. So the chromatography strips and solvents are too old. Migration pattern of radiopharmaceutical may be changed. Also, streaking of activity may occur. These can lead to erroneous results, so we have to use new solvents and dry strips prior to use. The next one is the strips and or solvent reverse. So total inaccurate results may be obtained. We have to repeat the entire QC procedure. And sometimes radiopharmaceutical spot is dried prior to solvent development. This will actually result in oxidation of radiopharmaceutical that may occur. Also, binding of radiopharmaceutical with a support media may occur, results in inaccurate assessment of radiochemical purity. We have to repeat entire QC procedure again. Number 6 is the strip is eluted past solvent front line. So if strip is eluted significantly past the solvent front line, the cut line must be changed to maintain the same RF value. Okay, so we cut it at higher cut line. So before I end, this is the to refresh again on the different aspect of radiopharmaceutical quality control. We have to ensure that the pharmaceutical parameters is covered, as well as the radioactive parameters also covered. With that, I thank you.